Hi everybody, I'm Dr. Deed Harrison, President of Chiropractic BioPhysics Seminars and Technique and President of Chiropractic BioPhysics Nonprofit, a spine research foundation. In this video that will be both available on my CE website, my good friend Dr. Dave Cruz's CE website through Web Exercise, and it will also be released on the Chiropractic BioPhysics YouTube video. I'm going to go through a critique in detail of a recent paper that was published in the peer-reviewed literature in the chiropractic profession and give a really interesting and unique perspective on this particular paper and what I see as an agenda-driven concept and an agenda towards chiropractic guidelines for insurance organizations, really designed, in my opinion, to actually limit chiropractic and take away chiropractic rights. And then we'll talk about the poor design of this particular study and what the literature actually says relevant to the topic that the study addressed. Now, this particular presentation is certainly a hot potato, and I'm sure I'll get some interesting feedback and fallout, and I'll get accused of doing whatever I get accused of doing, but I'm going to let the research and data speak for itself. So I titled this particular presentation, Agendas, Guidelines, Poorly Designed Studies, and a Legitimate Look at the Literature, the Sagittal Plane of the Lumbo-Pelvic Spine in Health and Disease. In my lumbar rehab textbook that my colleagues and I wrote in 2007, there's a detailed chapter that presents a lot of this information up until 2007. You'll see that I've realistically updated the data by presenting brand new research as well. But in chapter 5 at the end, you can really look and see the history of this agenda, where certain individuals in the chiropractic profession and in the healthcare arena, they do not want to accept a correlation between the lumbar lordosis and chronic low back pain. They do not want to accept the validity and value of spine radiography as the gold standard for assessing the shape and alignment of the lumbar spine. They don't want to accept the value of any information on an x-ray relating to any type of health condition, including back pain in a patient. That's what these individuals have been purporting for many, many years, and I summarized this in 2007, chapter 5 in this textbook. What I want to go through is the recent agenda-driven policy put forth by the ACA, and then some of the researchers in the chiropractic profession, either through ties to these organizations, through agendas of their own, or just through plain ignorance and jumping on a bandwagon. I don't know which one it is. They want to continue to push this particular guideline position statement by the ACA. This came out in August of 2017. Now, this is not a guideline in terms of a legitimate professional document. This is not endorsed or accepted by like the National Guideline Clearinghouse. This is just the ACA's personal opinion that was put out to the public to basically deter them from going to chiropractors that use spine x-ray to analyze the biomechanical alignment of the spine. ACA stated this: don't go to a chiropractor that takes x-rays to understand low back pain. Don't go to a chiropractor that would take follow-up x-rays due to in a desire to look at the treatment effects of interventions designed to change what you see on the initial x-ray. So no follow-up x-rays. This was an ACA agenda, public policy, that they put out as what they called the Choose Wisely guidelines. Now, many people in the profession since August of 2017 have really vehemently attacked the ACA guidelines. Well, the reality of it is, I knew that this was going to happen. The group that I work with, we knew exactly what was going to happen with these guidelines. Insurance organizations were going to take this position statement, even though it's bunk, it's total nonsense. It is a public policy of a small fraction of the chiropractic profession. Less than 10% of the entire chiropractic profession is a member of the ACA. So you've got 10% at best of the profession behind this statement. They make it look like it's the entire profession. Well, guess what? The Choose Wisely ACA guidelines made it into the Blue Cross Blue Shield policy guidelines for the chiropractic profession. How in the hell does that happen? How in the hell does an insurance organization get a hold of a position statement of the ACA and rewrite their guidelines for public policy for their members where they limit chiropractic care? Here's what Blue Cross Blue Shield just released, September 25th, 2017. They said, choosing wisely, questions to ask when treating low back pain. There is currently no data available to support a relationship between changes in alignment or other structural characteristics in patient improvement. No data, not conflicting data, no data whatsoever, none. You look at this, you go, really? That's quite a statement. There's no data at all in the scientific literature supporting alignment of the spine linking to patient outcomes. Furthermore, there is no known correlation between performing routine or repeat imaging studies to monitor a patient's condition and improve clinical outcomes or meaningful changes in a patient. Meaningful changes in patient management. No known, none, nothing exists. They just said it's a blanket black hole, no data. Gets better. They said there's no data available to support a relationship between changes in alignment and patient improvement, and nothing that shows improved patient outcomes. That's Blue Cross Blue Shield. You know where they got it? They got it from the ACA Choose Wisely guidelines. Do you really think it's an accident that this made it in, or do you think that these people networked together somehow? I'll just let you run wild with your conspiracy theory imagination. But I can tell you what viewpoint I take. I don't think it's an accident. That's my professional opinion. How does that get into a proper insurance guideline when it's nothing more than public policy by a small faction of the chiropractic profession? Now, an update of this. Recently, within the last 30 days, this paper was published in one of the top journals in chiropractic. Not one of the top spine journals in the world, one of the top journals in chiropractic. This is a PubMed peer-reviewed journal. It's called the Journal of Chiropractic Medicine. Now, my team and I, we've published in this journal too. Well, this particular paper came out, and I personally see this as a big-time agenda that couples with the ACA guidelines and what's happening with Blue Cross Blue Shield. This particular project came out recently by Schwartz et al., Schwartz and Haas. Relationship between radiographic lumbosacral spine mensuration, meaning measurement, and chronic low back pain intensity. A cross-sectional study, JCM 2018. Okay, now you'll see the methods of measurement that they used. Here's what they did. They took 352 chronic low back pain subjects that were part of a randomized trial, and they took their x-ray data and looked at, is there any correlation between back pain intensity on a simple numerical rating score and lumbar radiographic alignment? Seems like a relevant study to do. However, let's understand, number one, it's simple pain scales. Where's the disability and where's the health status questionnaires? That's number one. Lumbar lordosis, lumbosacral disc angle, and sacral inclination were measured. So I look here and I go, lumbosacral disc angle. I'm not a real big fan of that. That's not the same as distal lumbar lordosis. What that is just the wedge index of L5-S1, which may or may not correlate to low back pain or anything other than there's some disc degeneration at that level. But it's not really a grade of disc degeneration by itself. That's one measurement. The sacral inclination angle, the posterior body of S1 relative to vertical. Now that is a reasonable measurement. That looks at the inclination of the sacrum and the sagittal plane. There's a couple ways of doing it. You can do the Cobb angle, which is the S1 in plate to horizontal, or the posterior body tangent like they've done here. And then they did L1 to L5 lumbar lordosis. The problem is they used the 4-line Cobb angle for this. We're going to talk about this. Why would an author today in 2018 use a protractor and a pencil and draw a 4-line Cobb angle when there are computerized methods that take away the four lines and do it in 2, and therefore you get a much smaller error measurement? Now this has been known since 1994. 6, that this cob angle, the way they've done it, since 1996, has an error of up to plus or minus 10 degrees. This is a huge problem right away. This is a red flag. Anybody doing this today in 2018 either doesn't realize the fatal flaw of this or has an agenda to indicate what they're trying to prove, or trying to find, if you will. Nobody should be doing a 4-line cob angle by hand. We live in the world today where you have computerized technology. 2 lines, less than half the error. Here's what they identified. No significant correlation of the angles with pain or age. Interesting. That's actually opposite of what's been found in the literature. In normal subjects, what you find is there's a dramatic difference in the lumbar lordosis in age-related spine changes. I'll show you some of the evidence. Number 2, no correlation with angles and pain. That's exactly opposite of what's been recently found in the scientific literature and what has been found in the past. Here's what they conclude. There's no correlation between lumbar lordosis and pain levels for people with low back pain, chronic. Use of lumbar spine radiographic measurements in the management of pain for people with low back pain is not recommended. Now, that's not the worst of it. Here's their actual, in the paper, practical applications. Now you can see where they're going with this. Now you can see what I would call the actual behind-the-scenes agenda. This study adds to prior studies and practice guidelines which state that the use of radiographs to assess posture in patients with chronic low back pain is not supported. In patients with chronic low back pain, the use of radiographs to assess posture will likely not affect patient management or care. Oh man, that's a big, big statement made by Schwartz and Haas. That's a completely agenda-driven statement favoring one side of this issue, and the side that limits chiropractic practice, that limits chiropractic rights with radiography, and limits the ability of a patient to get proper patient-centered care that's based on exactly what's wrong with their spine on the inside. That's nothing more than an agenda to limit what a chiropractor can or can't do under an insurance guideline policy or under state board-driven guidelines. Now let's take a step back. Let's go, well, what's normal in the lumbar spine? We have to understand some normal things before we really get into the fatal flaws with this particular study. And by the way, other studies in the literature that have done the same thing that Schwartz and Haas did with some of the methods. What is normal for the lumbar spine? Well, we know and have known since the 1990s that the lumbar lordosis is a non-uniform rate of curvature. 2/3 of the curve exists down at the bottom 2 segments of the spine, L4 to S1. Only 1/3 of the curve exists above the L4 segment. So we know this lumbar lordosis has been modeled in 2 ways. Number 1, like my group did in the 1990s, we modeled this with an elliptical configuration model where we had an increasing distal lumbar curve. So an ellipse is flat at the top and increases its curve at the bottom. That's one way to model this non-uniform rate of curve. Other authors in the European journals, in the European Spine Journal, etc., other authors have modeled the lumbar lordosis as 2 different radii of circles, where the bottom part of the lumbar spine has a very tight curve, a small radius, and the upper segments of the lumbar curve has a very long radius or a very flat curvature. You have to use 2 different radii of curvature to model the lumbar curve. It's non-uniform in its rate of curve. That being said, you cannot analyze the lumbar lordosis properly by only looking at the L1 to L5 cob angle and then throwing in a lumbosacral disc angle. It does not tell you what geometric shape this thing is. It does not tell you the distal lumbar curvature contribution to the total curve. Now, this is a paper that we did in 1997 on normal subjects. Normal subjects, and you got to forgive me, I patched something over here really quickly. What I'll do is I'll just escape out and I'll talk to you while I'm working through this. This particular paper that we did in 1997, what we showed is that the lumbar lordosis is a non-uniform rate of curve. Most of the curve happens at the bottom of the spine. That's what we identified. Now, if you look at the data in the literature that we looked at in the 1990s, what you will find is indeed every study that looked at normal subjects, every one of these studies found that there's more curve at the bottom of the lumbar spine than in the middle and the upper. So, for example, the Stegner et al. Study, if you look at the L5S1, that's the relative rotation angle, that's 21 degrees, okay, 21 degrees. Now that's not the lumbosacral disc angle that they're reporting. It's the L5S1 segmental angle, not just the wedge angle of the disc. If you look at the Wombolt study, 21 degrees. You look at the Bernhardt and Bridwell study. You look at this, they get 21 degrees. It's the way you match these together. Jackson and McManus, 24, 25. Gelb et al., 24. So you get the idea, it's in the low 20s in all these studies, okay? All these studies. Now, here's what the Schwartz and Haas paper did. They looked at the wedge angle at L5S1, and they identified that this lumbosacral disc angle is 14.5 degrees. Now, number one, if it is the same measurement that was done in normal subjects, you will see a dramatic difference in the magnitude of this angle between their low back pain studies in the Schwartz et al. And Schwartz and Haas study and what's found in the literature on normal subjects. The reality of it is, though, the way Schwartz and Haas chose to make the measurement, they underestimated the lumbosacral curve from L5 to S1. It's underestimated. Why would you do it that way? Why? Why are you reporting that angle? What is the reality? You're trying to say that you looked at the distal lumbar curve, but did you really do it properly? And if you did, in fact, your data contradicts what's found in normal subjects without back pain. Okay, so one of two scenarios occurs here. And this is not just one paper I'm going through on normal subjects. There's 7 of them that have found the same thing. When you see that, you go, that is reality. That's the trend in what we see in normal populations. So again, you look at the data from Schwartz and Haas and you go, it's conflicting. It's the way they made the measurement, and it also points out that low back pain subjects have a reduction in their lumbosacral disc angle, by the way. The next paper we did in 1998, modeling the lumbar spine with the ellipse. This is where we physically showed that we can model the lumbar spine with a piece of an ellipse. It's a non-uniform rate of curve. It's flatter at the upper, and then it increases dramatically in its distal lumbar curve, where this area contributes 2/3 to the total. If you just look at 4-line Cobb angles, you will not see this elliptical curvature. Okay? In fact, our data that we did in a separate paper in 1998 in the Journal of Spinal Disorders, we showed that our elliptical model could accurately discriminate statistically between chronic back pain, normal subjects, and acute subjects, and pathology papers. Now, of interest, neither of our 3 papers are referenced in the Schwartz and Haas study. This 2018 paper in the Journal of Chiropractic Medicine, they completely ignored what is available in the literature from the mid-1990s and up. Why would they do that? They were aware of these papers. These are papers that are in some of the top journals in the world, and these are studies that have led to the understanding of how the lumbar spine actually looks and the relevance of this model and distribution to chronic back pain versus normal subjects. The reality of it is, when we look at the way we made the measurement in our papers, we use 2-line angles to make the measurement of total lumbar curve. We use the back of the body of L1 and the back of the body of L5. In fact, this measurement has been shown to have a standard error of measurement of 2 to 3 degrees at the segmental level, as well as the total angle of lumbar curve. Why didn't Schwartz and Haas make the measurement along the posterior bodies of L1 to L5? Why didn't they do a 2-line Cobb angle using computerized technology L1 to L5? What is known as of 1996, here's the paper I was referring to, in Spine in 1996, Pauly et al. Showed that although it's reliable, it has good inter and intra-examiner reliability correlation coefficients. It has a very high standard error of measurement. Now, Shorts and Haas know this to be true. They know it. What they did is they said, oh, well, this measurement, 4-line Cobb angle, has high reliability. End of story. Wrong. Not end of story. You've got a measurement that has an error of plus or minus 10 degrees. You know what that means? That means a 20-degree lumbar curve and a 40-degree lumbar curve are non-discriminated against with this method. So you can have 30 plus or minus 10 and it covers everybody. You cannot distinguish between people that have loss of the lumbar curve at 20 degrees versus people that have a 30-degree curve versus people that have a 40-degree curve. I mean, come on, give me a break. Am I the only one that gets this? You know, do you think it's an accident that they chose the 4-line Cobb angle? It's either that or they're so ignorant to the data. I don't understand. Which one do you think it is? I've got my personal perspective on it. You can develop yours. If you've got something that has such a high standard error of measurement, why would you use it? Even though it might be reliable, it is not sensitive enough to identify differences between people. Here's what Pauly stated 22 years ago. 22 years ago, the measurement of lumbar lordosis is reproducible and reliable if the technique is specified, and one accepts a 10 degrees as an acceptable variation from the mean. Factors that affect the reproducibility of measurement include in-vertebra selection, especially with transitional segments, and the vertebral end-plate architecture itself. And let's throw this in there, the ability to truly draw perpendiculars. Why would you want to sit there with a protractor and try to line up the lines and make sure it's 90 degrees when a computer can do it precise and perfect every single time? Waste of time. We know this, the lumbosacral curve is the biggest. Now this is the posterior tangent method, not the Cobb angle, like the previous data I showed you where it was in the mid to low 20s. Okay, when we use the posterior body lines, we get in the 30s. When we use the Cobb angles for lumbosacral lordosis, we're in the mid to lower 20s. The Shorts and Haas data somehow found it in the 14 to 15 degree range, meaning that either the measurement is inappropriate for the lumbosacral disc angle that they did, or that the chronic back pain subjects truly have a loss of the lumbar curve. So this is the normal shape and distribution of the lumbar lordosis, an increasing distal lumbar curve. This is a chronic back pain subject with loss of the lumbar curve, disc disease, retrolisthesis, vacuum sign, etc. Now, let's look at this paper in a little more detail. According to Shorts and Haas, lumbar hypolordosis relevant to chronic low back pain is controversial in the literature. For that statement, they made it twice in their introduction. They reference 4 papers. Now, number one, I look at the years on these papers and I go, you couldn't find anything earlier than or anything more recent than 17 years ago? The most recent reference you're gonna throw out is from 2001, 17 years ago, and then you're gonna throw it in 33 years later in 1985? That's the data you're gonna give me to say that this is controversial? Now, right there, you're gonna see a slide coming up where you're gonna go, oh, whoa. What was there other data they could have, referenced? The reasonable part of doing a paper in the literature, you have to summarize past and present and show future. You don't just show past stuff and go, oh yeah, it's controversial because I'm gonna reference studies 17 to 33 years ago. Whoops, what happened to the more recent data? Let's find out. So here's the papers they reference. Udis et al., Physical Therapy 2000. Well, number one, that's not an X-ray based study. It's a surface contour study that looked at surface alignment of the lumbar lordosis relevant to back pain. So no kidding they found controversial results. We're talking about X-ray here, yet you're gonna reference studies that don't take X-rays. Come on, give me a break. Number two, can't pronounce it, I'll let you pronounce that lead author's last name, my apologies. Journal of Spinal Disorders, 2001. Another surface contour assessment. Lo and behold, they picked the first 2 references, the most recent ones, and they don't even have X-ray in them. It's surface contour. How is that possible? Number 3, the Hansen study, 33 years old. Guess what? X-rays, but the X-rays were taken lying down, non-weight bearing. So no wonder there's a controversy. 3 out of the 4 references that they say it's controversial, it's because the methods are so terrible, you can't make a conclusion and claim based on them. The only reference that's actually legitimate in the 4 that they bring up is the Jackson and McManus paper. This one looks at 100 control subjects, normal, to 100 chronic low back pain subjects using standing upright X-rays, using not just total angle of curve, L1 to L5, but segmental angles of curve. And guess what they found? Chronic low back pain subjects have statistically a loss of their distal lumbar curve and sacral inclination. It's not controversial. It's only controversial if you bring up 3 papers that have invalid methods and try to say it's the same as the only study with a valid method. 1994, Jackson et al. Read the paper. It's a groundbreaking study. It finds distal lumbar curve shows strong differences between normal subjects and chronic back pain subjects. How is it that Schwartz and Haas make this statement and it skates by and gets in and it's controversial? How can you use surface contour papers and a non-weight bearing X-ray paper to claim that the study that did legitimate analysis is controversial? How do you do that? I don't know. Here's the Jackson paper. 100 normal subjects matched to 100 chronic back pain subjects. Here's what they identified. Total lordosis on X-ray is significantly less in patients. It's not age or sex related in back pain subjects. In back pain subjects, the lumbar curve is not age or sex related. It's more than likely due to a loss of the lumbar curve because of the pain or driving the pain. Patients with low back pain tend to stand with less distal lumbar lordosis, but more proximal. In other words, it changes the ellipse to a circle. 1994. Not controversial, one of the best studies done on the topic at its time, right? Here's the paper we did, Journal of Spinal Disorders in 1998. We found the same thing that Jackson et al. Found. We found that loss of the lumbar lordosis, specifically in the distal lumbar region, is the mechanism that low back pain subjects have, and it's likely causing or contributing to their chronic low back pain. This was 1998, the Journal of Spinal Disorders. This is a very important paper because it doesn't just look at X-ray lines. It looks at physical elliptical modeling, which is a higher level of analysis. And then as a follow-up to this study, we actually looked at sensitivity and specificity of the findings, showing that we had moderate to good sensitivity and specificity. In other words, we could identify true positives versus true negatives, false positives versus false negatives using receiver operating characteristic curves. Of course, this particular paper was not referenced or mentioned by the Schwartz and Haas, right? How is it that they leave that out? How is it that you're talking about a subject of chronic low back pain and lumbar lordosis, but yet you leave out some of the groundbreaking earlier studies on this particular topic, right? So to summarize, if you want to accurately assess the lumbar lordosis in people, you have to A, do a total angle of curve, and B, do a 2-line measurement method, not a 4-line Cobb angle. C, you have to look at segmental or relative rotation angles to understand the distribution of the curve. Is it different in chronic back pain subjects, or is it different in intensity of those chronic back pain subjects? And then, number 4, when we do more sophisticated modeling methods, the model can actually tell you whether or not there's differences in subjects compared to simple line drawing methods. So there's hierarchies of methodology here that we have to look at. Also shown up here is something very important, sagittal balance. We'll get to that. Check it out. Of interest, here's something very significant that was missed in the Schwartz and Haas paper. Now, unusually, they reference this paper. It is referenced in their 2018 paper. They apparently read this study. So they read this paper, but yet they didn't look at the analysis that this paper did as going, whoa, maybe we should look at this too. Check this out. Kobayashi et al., Spine, 2004. 12-year study on individuals between 70 and 85 years of age. We want to identify factors that correlate or relate to age-related spine deformity and back pain and disability in the elderly population. Here's what this paper identified. It's not just the magnitude of the lumbar lordosis that is a problem in the aging spine or in the patient population with pain and disability in their later years. The reality is this: L1 to L5 lordosis, when it is 80 to 100% of the sacral base angle, subjects age properly with spine stability of the alignment. They don't get spine deformity. Oppositely, in subjects whose lumbar curve is less than 80% of the sacral base value, the spine was found to deform into anterior sagittal balance and loss of the lordosis over the 12-year period. Stop right there. Now, Schwartz and Haas, they looked at L1 to L5 lordosis. Even though they did a 4-line Cobb angle, they still had data on it. Number two, they have sacral inclination angle. They could have easily looked at the correlation between those two variables to identify if you fall out of a certain range, you may actually be more likely to have more severe and more frequent low back pain. Why did they not look at it? They referenced the Kobayashi et al. Paper. They actually referenced that in their data. So you look at it and you go, well, they knew about it, so why didn't they go the extra step and look at the relationship of lumbar lordosis to sacral inclination as a predictor of back pain intensity, when it's well known in the literature today that that is one of the most important characteristics of a normal spine versus a non-normal spine. I'll show you more on this coming up. My group and I did this in the early to mid 2000s as well. We discussed the relationship of the lumbar lordosis relative to pelvic morphology and the thoracic curve relative to lumbar lordosis and pelvic morphology, and sagittal balance, sagittal gravity lines relative to S1 in back pain versus normal subjects. We did this in several projects. One was in Spine 2003, one was in the Journal of Spinal Disorders in 2005, and then others were in Surgical and Chiropractic Research Society conferences that I know one of the authors was present at when at least one or two of those papers was given. This data is known in the literature. The data is known in the literature. You cannot just look at one variable. You have to look at relationships of the lumbar lordosis to the distal curve. You have to look at lumbar lordosis versus sacral inclination. You also have to look at full spine gravity lines. Conflicting data exists in the literature. Now, of interest, this paper seems to have been referenced as well as the Schwartz and Haas in the Schwartz and Haas paper. But for some reason, they didn't look at what's going on. Look at this. Lumbar lordosis, L1 to S1, 4-line Cobb. Now, I still have a problem with the 4-line Cobb angle in this particular project. However, notice when they look at sacral inclination with L1, you get different results. My point with this is, one measurement, L1 to L5 4-line Cobb angle, doesn't tell you the whole story. If I change it up and go L1 to S1, maybe I get an entirely different look at what's happening. Maybe there's a difference between the lumbar curve relative to the sacrum in chronic low back pain. So here's what was found in this paper, Journal of Orthopedic Science, 2001. And this is on older subjects, 5th decade to the 8th decade of life. Look at the sample size. This is not a small sample size. Schwartz and Haas claim previous studies have smaller sample sizes. Not this paper. 253 with no pain, 236 with chronic low back pain. Age, weight, height, sex, and pain scores. Here's what they identified. No correlation with sex and age and lordosis in their two populations. Chronic low back pain, however, was found to have a decreased lumbar lordosis compared to the normal subjects, highly statistically significant. And then opposite to what Schwartz and Haas found, lordosis is inversely correlated to pain intensity scores, meaning The more reduction your lumbar curve has, the higher your pain scores are, okay? So the smaller your lumbar lordosis, the higher your pain. It's inverse. The lower your pain, the bigger your lumbar lordosis. This is exactly opposite of what Schwartz and Haas found. Now, of interest, this is a chronic back pain group correlated to no pain. There are strong differences. Of interest, this is not a young population. This is an older population. This is a very important finding. It completely contradicts what Haas and Schwartz have stated. The proper thing to have stated in the Schwartz and Haas study is the way they chose to make the measurement has no correlation to back pain intensity. However, other measurements have shown validity in discriminating between, number one, pain and non-pain, and number two, between low pain and high pain in subjects with chronic low back pain. That would have been the appropriate conclusion to make. The Corrective paper. How did this one get missed? This one is missed by the 2018 Schwartz and Haas study, when in fact, this is one of the best all-time papers done in the early 2000s on loss of the lumbar lordosis and chronic back pain. Here's what this group of authors did. Corrective et al., Journal of Spinal Disorders and Technique, 2002. 100 normal subjects with no pain. 100 chronic low back pain subjects greater than 6 months of age, or greater than 6 months duration. They matched the chronic pain to the normal subjects for age, gender, height, and weight. Wow, this is really important. Body mass index. We're going to talk about this as well. The Schwartz and Haas paper, they didn't even consider body mass index as a variable that may in fact influence their data analysis. If you don't look at body mass index in subjects, you can't understand their lumbar lordosis, because BMI has been shown to be an important contributor to the magnitude of lumbar lordosis. I will show you a paper on it. Look at this. Match these subjects for age, weight, height, sex, and occupation. These are all men, and these are all blue-collar workers. Look what they identified. Low back pain, general health, physical function, emotional function, social function, and just general pain all correlated to the following things in this paper: age, height, L1 to S1 inclination, distal lumbar lordosis, aka the elliptical lumbar curve, L2 to L5 disc indexes, and the distal lumbar disc index taken as a whole. Here's what they conclude. This is their conclusion in their paper. There seems to exist a link between sagittal lumbar spine radiography and subjective assessment data as measured using the SF-36. Now, the SF-36 actually has a lot more data than a simple pain score as done by Schwartz and Haas. This paper strikingly contradicts the Schwartz and the Haas conclusion. Why? Well, more sophisticated methods. That's what I'm going to say. More detailed analysis of the lumbar lordosis, better pain and disability assessments in terms of the SF-36, and then a properly done study where you take back pain and match it to normal subjects. So how is this missed in the 2018 paper? How is it that they can make such a strong statement that guidelines shouldn't even allow clinicians to take x-rays of patients with low back pain because radiographic data is irrelevant according to the Schwartz and Haas paper findings, right? You can see what's up. Now this is the holy grail. Well, one of them, right? Here, I always say that, but this is the big one. This came out in May of 2017. Okay, May of 2017, the Chun et al. Paper comes out. Now, the Schwartz and Haas paper is submitted for publication in September of 2017. Now, as an author of a paper, you're required to do an updated literature review. How is it that this paper, which is actually the best paper ever done on the topic to date, in terms of chronic back pain and loss of the lordosis on x-ray, how is it that this one doesn't find its way into the Schwartz and Haas study? How is it that you misreference this, or don't even reference it? Sorry. You know why? Because it would completely refute your claims and your findings, because this is what researchers look to do. This is a meta-analysis. This is, let's look at the best studies done to date up till 2017 that look at radiographic analysis of subjects with chronic low back pain, age and sex and occupation and or height and weight matched to normal subjects. Let's see what the actual data says and what the best studies in the literature say, and then let's do a sophisticated analysis using meta-regression analysis on these study findings. So then we'll get a proper statistical consensus on, does loss of the lumbar lordosis contribute to, cause, or correlate to chronic low back pain. They identified 13 studies with 796 chronic low back pain subjects versus 727 control subjects. Findings, quote, in the meta-analysis: strong relationship between low back pain and decreased lumbar lordotic curvature was identified, especially when compared with age-matched healthy controls. End of story. Age-matched healthy controls is how you compare a condition group to a non-condition group. Okay? You look at age and gender and occupation, and you find out, is there a difference? Does one group have a different finding? Yes, they do. Loss of the lumbar lordosis on x-ray is in chronic low back pain. Among specific diseases identified in these 13 studies, low back pain by disc herniation or disc degeneration was shown to be substantially associated with loss of the lumbar curvature, which makes perfect sense. So the reality of it is, why was this paper not referenced in the Schwartz and Haas paper? Well, you know why? Because you can't change consensus meta-analysis statements by one study that's flawed and come up with, oh, x-ray shouldn't be used in chronic low back pain guidelines. So if the Schwartz and Haas paper actually addressed this particular paper, 2017, they got a problem on their hands. They got to go, well, our paper has really conflicting data. Why? Well, I'll tell you why. Poor methodology, lack of analysis properly of the distal lumbar lordosis, using a measurement system that has a huge error margin. It may be reliable, but it has a huge error margin. It's not sensitive enough. And lack of more sophisticated analysis. They didn't look at the total curve relative to the sacral base angle, right? Why wouldn't you do that? It gets worse. There's actually another systematic literature review that found the same thing as Chun et al. This one was also published in May of 2017. Now this one of interest looks at surface assessment. So Schwartz and Haas claim that the lumbar lordosis, loss of the lumbar curve and back pain is controversial, and they reference surface contour studies, but those studies are older studies. Even looking at surface contour studies, as this systematic literature review and meta-analysis did, there is a strong correlation between loss of the lumbar lordosis on surface contours in chronic back pain. This paper looked at studies only that had 1 year follow-up of the data. Look at this. 12 articles with over 5,000 subjects were looked at. Meta-analysis revealed the following: lateral flexion range of motion, so your range of motion in left and right bending, loss of the lumbar lordosis, that's hypolordosis, and restricted hamstring range of motion were statistically correlated with, and the development of low back pain. So in subjects that don't have low back pain, you get it because you have loss of the lumbar curve. How is it that this paper can be missed by the Schwartz and Haas study? I'm like pulling my hair out. I'm like, am I the only one that is aware of this data? Am I the only one that looks at this and go, how is it possible? What's going on here? Is there an agenda? Are these people just not aware of the literature? What is going on? I don't get it. Well, I'll let you formulate your own. we found that a restriction in lateral flexion and hamstring range of motion, as well as loss of the lumbar lordosis, were statistically associated with increased risk of developing low back pain. Holy cow. There's another holy grail. As if the meta-analysis wasn't the holy grail, which I think that really refutes the Schwartz and Haas paper. Here's the big one. Today, it's unacceptable in a study looking at the lumbar lordosis in its relevance of back pain or non-back pain, it's completely unacceptable not to look at pelvic morphology. Now, pelvic morphology is a topic that came out in 1986, and it was first put forth by During et al. Of interest, Schwartz and Haas reference the During paper. It is their reference number 8. The issue is they either did not understand the relevance of the During paper, or they chose to ignore the relevance of pelvic morphology. Now, since 1985, most of the literature in spine care, specifically when you look at biomechanics of the lumbar lordosis and before and after surgery clinical trials, and on normative data and non-normative data populations, you will find that the top papers are looking at pelvic morphology. In fact, a lot of journals won't accept a paper if you don't do this. Now, how do I know? Well, I happen to get around a little bit in the spine field. I happen to review for a lot of different journals. If you don't look at the pelvic morphology variable and how the lumbar lordosis is correlated to the pelvic morphology, you cannot understand whether or not somebody has a proper lumbar lordosis relative to their anatomy, or if they have an abnormal fit of their lumbar curve relative to their anatomy. Now, pelvic incidence angle. This is the angle that's most popular in the literature, the angle of pelvic incidence. It is drawn by a perpendicular line off the mid-sacral end plate, and then from the mid-sacral end plate, a line drawn to the hip axis, which is a bisection point between the two femurs. The angle between those is called the angle of pelvic incidence. Okay? Now, this angle is very, very important. So the angle of pelvic incidence is one of the most common measurements done, and that's the one we'll focus on. But there are other measurements, specifically one that I did called the posterior tangent pelvic incidence angle. Now, I did this in 2005. I presented this and published copyrighted notes, and then I presented this at different peer-reviewed research conferences in 2005 and 6. Well, in the literature, somebody published this in 2007, and it's the same angle, they just put a different name on it. I can look at it historically and say, well, I did it first 2 years earlier, but that's just, being a little trivial. But the reality of it is the back of the body of S1 relative to the posterior superior corner of S1 to the hip axis, that angle that I called the posterior tangent pelvic incident angle is also a measurement of pelvic morphology. Now, why are these two measurements important? Well, this has to do with the anatomy of a person's sacrum and how the sacrum fits inside the ilia at the SI joint and that relationship to the hip axis. Now, here's the deal. In primate populations, the sacrum from the side is very linear, it's very straight. There's no significant sacral kyphosis. Well, in these populations, they will have a very shallow or small pelvic incidence angle, no matter which method you choose to measure. Of interest, some people have type 0 sacrums, which you could say genetically are kickbacks to primate populations or Neanderthal populations, etc. Normal subjects in the adult population should have what I called a type 1 or a type 2 sacrum. These are mild to moderate sacral kyphosis, and you can see that the angle of pelvic incidence, if you drew it with your, just imagine it, that angle would be quite large. It would be like 45 to 65 degrees. Well, these are the normal ranges for the adult human sacral morphology. Okay, and related to the pelvic morphology. And then there's a type 3, which is a very strong sacral kyphosis, which if you were to look and eyeball the pelvic morphology measurement, you would see that this one had a very large pelvic morphology. Okay, the reality of it is type 3 will have hyperlordosis in the person and increased sacral inclination. Type 0 will have hypolordosis and decreased sacral inclination, and type 1 and 2 will be, quote unquote, the normal elliptical lumbar lordosis, where the sacral base angle is 35 to 45 degrees, and the lumbar lordosis from L1 to L5, if you use posterior body tangents, will be 35 to 45 degrees. So sacral morphology and pelvic morphology are connected together. Now, why do this measurement? Well, the reality of it is, it's been known since the 1990s that the following statement is true. Over 20 years ago, it was found that pelvic morphology has a strong linear correlation to sacral base angle, okay? So here's some references for that. Now here's a graph out of one of these papers. Pelvic incidence angle, pelvic morphology measurement in the mid-50s. If I go up, I find this point right there on my mean line, and I go over and I find 40 degrees for the sacral base angle. Do you think that's coincidence that a pelvic incidence angle in the mid-50s gives you a sacral base angle that's 40 degrees? It's not coincidence. This is the normal relationship of the pelvic morphology to sacral inclination. And if I go down to 30 degrees, you'll find an approximate 25 degree sacral base angle. And if I go up to a 90 degree pelvic morphology angle, you're going to get a sacral base angle that's over 60. Now, each dot is a normal subject's data. So one dot, this is a person. Let's call him Deed. And let's say Deed's pelvic morphology is in the lower 40s and his sacral slope is just above 40. Now, Deed's an outlier. Most people fall on the trend line, right? However, look at this. If I go to 50 and I find 50 degrees, you will not find somebody with a 50 degree pelvic morphology that has a sacral slope that's in the lower 20s and below. It doesn't work. Why? Well, because they're a normal subject. They're not a chronic pain subject. When you look at a chronic pain subject, they won't fit this trend line. They'll have a totally different trend line. It's been known for a long time. I'm going to show you some updated papers on this. Now, I started reading this in the early 2000s, and we started doing this in CBP technique in 2005. We started saying the only way to truly find out if somebody has a normal sacral base is to look at their pelvic morphology. The sacrum has to match the pelvic morphology. It's the same with the lumbar lordosis. The lumbar lordosis has to match the pelvic morphology in normal subjects. You can look at data in the literature. There's a moderate to strong correlation between lumbar lordosis and pelvic morphology in normal subjects. So normal subjects, if I have a proper pelvic morphology, I will have a proper amount of lumbar lordosis. Now, if you look at this graph here and you go, this is a 55 degree pelvic morphology angle, this is roughly like a 42 to 44 degree lumbar lordosis. It has to do with the way each author makes the measurement. The lumbar lordosis might be a little more or a little less. Are they using T12 to L5 as their measurement? Are they using L1 to L5, etc.? But you get the idea. As pelvic morphology increases, the lumbar lordosis increases. As pelvic morphology decreases, lumbar lordosis decreases. Pelvic morphology is an anatomical variable that is unique to the person that should not change dramatically as a person ages. Now, due to the shape of the sacrum as it deforms as we age under gravity and postural loads, the pelvic morphology measurements will actually subtly change as we age. However, you can still do age-related population norms. You can go, well, here's the measurement when I'm 50 and 60, and here's the trend line. It's known in the literature that normal subjects behave this way. Here's the deal. This is the way the human has been designed. Whether it's creation, whether it's design or evolution, I'll leave that to you. But if you look at anthropology studies and comparative anatomy studies on early hominids versus normal humans today, you will see early hominids had a shallow pelvic morphology and had a straighter sacrum, not shown in this picture. They also then had a straighter lumbar lordosis and sacral inclination angle. They also had a forward shift of the gravity line. Today's humans have a deep pelvic morphology, deep sacral base angle, deep lumbar lordosis, and a gravity line where the upper lumbar spine and thoracolumbar spine sits over the back of the sacrum, okay? Now, the problem is some people have throwback anatomy to early hominids and Neanderthals. Roughly, when you do population norms and bell-shaped curves, you'll see that approximately 17% of the population is on the low end of the bell-shaped curve, right? And they'll have throwbacks to this. Now, the deal is, in order to look at somebody's lumbar lordosis and decide, does it match their pelvic morphology, you actually have to measure pelvic morphology. And you have to do correlations between L1 to L5 and the sacral base angle, and L1 to L5 and the pelvic morphology measurement. And you have to look at sacral base angle, inclination angle, relative to pelvic morphology. If you don't do that, then you are missing the boat on whether or not this subject has an alteration in their lumbar lordosis. So if Schwartz and Haas read the During paper in 1986 and they understood it, then why did they not look at pelvic morphology in their population? Here's an update to the literature. And notice these were all available except for a couple to Schwartz and Haas. An individual's correlation between their lumbar lordosis and their sacral inclination, and the sacral inclination and lumbar lordosis compared to their pelvic morphology, has been demonstrated to determine the presence or absence of low back pain, disability, the need for intervention, and a person's unique outcomes. References 3 through 7. Further, the loss of the distal lumbar lordosis and its relationship to the lumbar lordosis minus pelvic morphology, as determined in a comprehensive analysis of the lumbar spine, not just the L1 to L5 lordosis as used by Schwartz et al., as well as full spine sagittal balance of A, C7 to S1, and B, T12 to S1, are essential biomechanical parameters known to be associated with low back pain, disability, and health. Now look at these papers for me for a minute. Spinal pelvic parameters in asymptomatic subjects without spine disease and deformity. A systematic review with meta-analysis. If you read this paper, it actually talks about quote-unquote normal subjects that have an altered relationship of their lumbar curve and sacrum to their pelvic morphology. In other words, an altered spinal pelvic relationship. These quote-unquote normal subjects will have abnormalities on pain and disability questionnaires that they were given as normal subjects. Isn't that intriguing? This article also reviews the data on normal subjects and their spinal pelvic correlation, and they reference studies that show when you do not have these normal relationships, you are the one that has back pain, disability, deformity, progression, etc. Now look at this one. The Mendoza paper came out in 2010. Why couldn't the Schwartz and Haas paper, find this? Why couldn't they find it? You go, it's 2010, Spine, one of the top journals in the world. Natural history of spinal pelvic alignment differs from symptomatic deformity of the spine. Huh, isn't that title interesting? Look at this one, 2018. Now, they couldn't have referenced this because their paper was submitted in 2017, but this is what the cutting edge state of the knowledge is in spine surgery now for the lumbar spine. Decision-making factors in the treatment of adult spine deformity. If you go to the European Spine Journal 2018, you will find that what they do is they look at subjects whose relationship, old or young, of their spine versus their pelvic morphology variables, when it falls outside of a certain trend, they're the ones that have higher back pain, higher disability, and they're the ones that the surgeons say need surgical intervention to normalize the spine-pelvic alignment. They're the ones that get the best outcomes after surgery at long-term follow-up. Now, these are actually consensus groups of surgeons around the world saying this is how we now do it. If that's how the surgeons do it, Why is it that Schwartz and Haas want to claim that radiographic analysis has no meaning to a chronic low back pain patient? No meaning whatsoever. I guess all these surgeons from around the world are guilty of malpractice then, because they look at X-ray alignment of the spine and pelvis relative to chronic back pain and disability and deformity, and then they use that data, to decide an intervention that's appropriate for the person, and then when they do it, they show the person gets better. But you know what? Schwartz and Haas and Blue Cross Blue Shield and the ACA said that there's no data for that. And I look at this and I go, really? 2018 consensus agreements by some of the top spine researchers in the world. Look at this one. The cohort study for the determination of reference values for spinal pelvic parameters. T1 and pelvic angles and global tilt in elderly volunteers. European Spine Journal 2016. They could have referenced this paper. Let me show you something. I'm just going to back out of this. Let me pull up these abstracts because this makes a very important point for us here. These abstracts are very important, okay? Check this out. I just want you to go to PubMed and identify these papers. Here's the Fujishiro et al. Paper, 2018, Decision-Making Factors of the Treatment of Adult Spine Deformity. A multi-center prospective adult spine deformity database was reviewed, looking at demographics, health-related quality of life, and radiographic measurements using multivariate analysis in both younger populations, less than 50, and older populations. Here's what they found. Okay, this is a multi-center trial, prospective multi-center database, and then they looked at it. Sagittal parameters were associated with this decision-making processes for these people on X-ray. Greater pelvic incidence minus lumbar lordosis mismatch in the younger age group and smaller lumbar lordosis index in the older group were most correlated with the decision to undergo surgery. Oh my God! That's exactly what I've been saying since 2005. When a subject has an abnormal fit of their lumbar lordosis relative to what their pelvic morphology should say, they're at high risk of back pain, disability, poor health status, and deformity progression. And the surgeons are now looking at that and going, we need to do surgery on these people because they don't know how to conservatively rehabilitate it, right? Or it went too far and now there's a lot of spine damage. Look at this in the older population. In the older age group, smaller lumbar lordosis index in the older age group was most likely to be correlated with decision to undergo surgery. Aside from the health-related quality of life measures, sagittal parameters were identified as significant factors for the decision-making process in adult spine deformity populations. Lack of lumbar lordosis relevant to the pelvic incidence was a strong driver to pursue surgical treatment. Oh my God. Top surgeons in the world are now using pelvic morphology, lumbar lordosis mismatch to decide what to do for a patient. Wow. Here's the cohort study. This cohort study, this one could have been referenced, 2016. How did Schwartz and Haas miss this? How did they miss it? The cohort study for determination of reference values for spinal pelvic parameters. Now, you're going to have to go through and look at the way their little acronyms work in the abstract, like T1 pelvic tilt angle. It's actually the angle between the vertical line of T1 relative to the sacrum. They're looking at not a distance, but an angle there. And then they've got the global spine tilt angle, right? That's the spine relative to itself, right? And so they're also looking at, look at this, sagittal vertical axis, pelvic tilt, pelvic incidence minus lumbar lordosis. You ever seen that before? And health-related quality of life. Here's what they find. The mean values for spinal pelvic parameters were as follows. Pelvic incidence minus lumbar lordosis, okay? That one right there is a very important finding. Here's what they identified, okay? What they identified is when that PI minus LL is high, you actually have an age-related mismatch of your lumbar lordosis to your pelvic morphology, indicating deterioration of the gravity line and deterioration of the Oswestry Disability Index. Okay, so it says here, based on logistic regression analysis, the deterioration of Oswestry Disability Index was mostly affected by sagittal malalignment. Okay, by sagittal malalignment. The TPA, which is the T1 pelvic tilt angle, and gravity line for severe disability was 26 and 33 degrees respectively. Conclusions. We determined reference, meaning cutoff values, for spine pelvic parameters in elderly volunteers. Similar to sagittal vertical axis, their new T1 tilt angle to the pelvis and gravity tilt angle correlated with HRQOL. Also, those two angles, pelvic tilt and the pelvic incidence minus lumbar lordosis, were worse in women and progressed with age-related deformity. Look at how many volunteers they looked at. 652 or 656 volunteers. Not a small sample size. Not conflicting data in the literature. Conflicting with some people's agenda that X-ray doesn't show any correlation to pain, disability, and health. But the actual data is exactly opposite what the Schwartz and Haas et al. Paper, A, would lead you to B, and B, what I think their measurement selection led them to find. Look at this. Natural history of spinal pelvic alignment differs from symptomatic deformity of the spine. Look at this, 2010. Gradual increase in pelvic incidence is described throughout the lifespan that is paralleled by an increase in the sacral femoral distance. Now these are just measurements that you do of the pelvis and the sacrum relative to the hip axis. It is not by an increase in the sacral slope angle. So what's happening is the sacrum is deforming inside this due to gravitational and postural loads. It's a shape change. This actually represents a morphological change of the pelvis as we age due to loading. Second finding, patients with symptomatic spine deformity, meaning they've got chronic back pain, represent or present with, compared to normal age-matched controls, increased C7 plumb line, that's the C7 to the S1, increased thoracic problems, in this case thoracic hypokyphosis, reduced lumbar lordosis, and signs of pelvic retroversion, meaning decreased lumbar curve and sacral slope angle relative to the pelvis itself. So this study is a cohort study looking at population normal versus symptomatic deformity. That's just 3 papers that I identified that are really well done papers that Schwartz and Haas absolutely could have referenced. Absolutely could have referenced. They had those papers available to them. Why is it that some of these did not make it into the Schwartz and Haas paper findings? Why is it? Here's what we know. We know my group has done this as of 2007. We identified, number one, the lumbar elliptical model in CBP can discriminate between normal and back pain subjects. Number two, we identified that subjects with chronic low back pain have an altered fit of their lumbar curve to their sacrum and their lumbar curve to their pelvic morphology and the sacrum relative to the pelvic morphology. We've done it in 2 separate papers. We identified that, for example, in this paper on 72 chronic low back pain subjects versus 72 normal subjects, we identified that subjects in pain have an altered fit of their lumbar curve L1 to L5 versus their pelvic incidence as measured with the posterior tangent pelvic incidence angle. Okay? So we have identified this. We know, I'm going to show you a graph out of one of these papers. We know that the normal subject's relationship of lumbar curve to the sacral base angle is moderate to strong. Correlation coefficient 0.6. Chronic back pain, reduced relationship 0.4. Lumbar curve to pelvic morphology measurements 0.34, 0.32 compared to chronic pain 0.24, 0.26. And then this one, the big one, sacral base angle to pelvic morphology, 0.728, 0.45. There's a different fit of the lumbar curve relative to the sacrum, and the lumbar curve relative to the pelvic morphology, and the sacrum relative to the pelvic morphology in normal subjects versus chronic back pain subjects. Chronic back pain subjects have an altered fit of their alignment relative to their pelvic anatomy and their pelvic shape. That is why they are having back pain, Shorts and Haas. That is why people like me and the top surgeons in the world take x-rays of their patient population. That is why they intervene and try to change the alignment of the spine, and that is why the people that get the best outcomes have the best resolution of their spine index to their pelvic anatomy. That's what's known in the literature today. That's the contemporary understanding, and anybody that says otherwise, they're living in the 1980s and 1990s, and they haven't kept up with the current findings and trends. What an embarrassment. What an embarrassment for chiropractic researchers not to be made aware of this, and then put this out in the literature, and then claim that guidelines should not even assess a patient's X-ray or lumbar spine with X-ray and chronic back pain. To me, that's an embarrassment. It says that all these papers in the literature are just agenda-driven, projects from, different researchers around the world. Come on, give me a break. To me, in summary, full spine radiography is the standard. Since the spine is a contiguous structure that is inseparable in function, it should be inseparable in an evaluation using spinal radiography, full spine alignment. You've got to look at gravity lines like I talked about. You've got to look at the thoracic curve relative to the lumbar curve. You've got to look at the lumbar curve relative to the sacral slope, lumbar curve relative to pelvic morphology, and then sacral slope relative to pelvic morphology. It's the only way to properly assess somebody. And it's been known for a long, long time that this is the way it works. Here's another one, 2005, I just can't help myself, the Glassman study. Look at this. 752 subjects with adult spine deformity. The C7 plumb line ranged from 1 to 271 millimeters forward. All measurements of health status showed significantly poorer scores as C7 plumb line deviation increased. It's linear. The more your sagittal balance on full spine x-ray is displaced, the more back pain, the more disability, and the more poor health status you have. It's been known for a long time, over a decade. Over a decade, the Glassman paper. Look at this. Also, patients with relative kyphosis in the lumbar region had more disability than patients with normal or lordotic lumbar sagittal Cobb angle measurements. In other words, segmental angle analysis is important. Of course, if you only do the L1 to L5 Cobb angle, the 4-line Cobb angle as done by Schwartz and Haas, you can't find segmental kyphosis, can you? Right? The Glassman paper is very important. Look at this. When you see people like this on a full spine x-ray that have a relative lumbar kyphosis and an anterior sagittal balance of C7 to S1, their disability is higher than subjects that have normal lumbar curves. It's known. The only way to find it properly is using x-ray techniques. You cannot see segmental analysis without x-ray, okay? The other thing is, look at this one. Here's a paper that was missed by Schwartz and Haas. The Lafage study, 2009, spine. Look at this. Pelvic tilt and trunk inclination in 125 adults with pain and disability related to spine deformity. Looking at not just lordosis measurements, but pain and health on the Oswestry Disability Index and the SF-36. Of interest, they found a linear correlation between the amount of loss of the distal lumbar curve and altered sagittal balance and back pain and disability. Here's what they had. In the group with the highest disability on the Oswestry, the worst subjects, they had the largest displacement from normal of their pelvic measurements and lumbar curve and sagittal parameters. On the SF-36 is inverse to the Oswestry. The higher the score on the SF-36, the better you are. So these two graphs, the top one is moving, in a positive slope, and the bottom one is moving in a negative slope. So when you look at this, you go, well, Deed, this one's showing the opposite of this one. Well, the reality of it is because the questionnaires are inverse in their relationship. Higher number on the disability is worse. Higher number on the SF-36 is better. So look at this. The more severely displaced alignment group on X-ray in the sagittal plane has more pain and disability, completely opposite of what was found in the Schwartz et al. Study. Why? Well, I'm here to tell you it has to do with the way they did their analysis. It's the measurements they chose to use. There's multiple papers out there like this. Look at the Indo paper, European Spine Journal 2010. It's well known that pelvic morphology and lumbar lordosis and sagittal balance correlates to problems. Look at this paper, Kobayashi et al., Osteoporosis International 2008. It's well known that alterations of sagittal alignment of the lumbar and thoracic curve cause problems. In this case, it's a predictor of compression fracture, right? Predictor of compression fracture. Look at this one. Lumbar kyphosis and back muscle strength predict GERD. 245 subjects looking at sagittal balance and mobility. Look at this. Their model is this. Lumbar kyphosis, sagittal imbalance, meaning your thoracic curve goes forward, hyperkyphotic, and C7 plumb line goes forward, and decrease in back muscle strength relate to the development of GERD. Normal subject without GERD, subject with GERD. It's not just back pain, it's health quality of life. How is it that Schwartz and Haas can write this paper and be so simplistic in their review and so simplistic in their measurement and reach a conclusion and then claim that that conclusion is the end all and it correlates to, guidelines that say that chiropractors shouldn't take x-rays for the spine? In my opinion, it's putting the cart before the horse. In my opinion, it's, I want to have a paper that finds this. I'm going to start here. How do I get there? How do I get there? I look at this stuff, you can say I'm wrong, you can say I'm right, but I can have an opinion on it. I can say, in my opinion, somebody's got an agenda. Somebody's doing something for reasons other than the benefit of the entire profession and the benefit of the person. I don't see this as patient-centered care. I see it as you have something you want to find and you can make a study find that. That's the way I see some of this stuff that's in the literature. How is it that these things are done in this paper? How is it that there's no mention of the other papers that I've referenced in here? How is it that this paper, one of the best papers that's come out in all of the literature in the last decade, how is it that this paper is missed by the Schwartz and Haas study? How is it that this paper finds that sagittal alignment on X-ray determines somebody's health status on the SF-36, and that people with spine deformity above the age of 18, if you have adult spine deformity, meaning alteration of your pelvic relationship and your lumbar curve and your sagittal vertical alignment, if you have those alterations, your health status is worse than people with cardiac disease, people with type 2 diabetes, people with pulmonary disorders, and people with rheumatoid arthritis. That's what this paper found. This paper said people with adult spine deformity, altered sagittal balance, these people are worse off than people with the most common 4 major disorders in all the industrialized nations: heart disease, lung disease, diabetes, and rheumatoid arthritis. Look what these authors state. The global burden of adult spine deformity is huge compared with other self-reported chronic conditions in the general population in 8 countries. The impact of ASD on HRQL, health-related quality of life, warrants the same research and health policy attention as other important diseases. And you find it on X-ray. How is it that Schwartz and Haas can publish a paper saying that you can't take X-rays of chronic low back pain people because it has no bearing, but yet papers like this come out in some of the top journals in the world? I wonder. I just wonder. Right? I just wonder. The older I get, I can't sit back and let this stuff go. I wrote a letter to the editor with my colleague Paul Oakley on this paper. I have no idea, excuse me, if the letter to the editor is going to get accepted, but the letter to the editor has to be short and concise. You can only do 8 references in 500 words. So I had a bigger story to tell. I couldn't get it done in 500 words and 8 references because it's a lot bigger than 500 words and 8 references. There's a lot more going on than can be addressed in a letter to the editor. When I put this out, I know it's going to be a hot potato, and I know that I'm going to get some fallout from it, but you know what? You got to stand for something. If you don't stand for something, you're walking the fence, and when you slip, you're going to get it right between the legs. You don't want that. Choose a side. Pick your side wisely. Figure out what's going on, but in the reality, you've got to do things in the best interest of not yourself, but in the patients out there. Do you really want to take away the right of a doctor to analyze a patient's spine on x-ray and see if their alignment is different in that person compared to somebody else that doesn't have the condition? Do you really want to take that right away? Do you really think it's illogical that somebody with back pain could have an alteration of their alignment relative to their pelvic anatomy, and that explains why they have back pain compared to a normal subject? Do you really think that's illogical, or do you think that that is one of the most logical frameworks of understanding the human spine and disability and disease that there is out there? I mean, think about that for just a second. Think about how well known this topic really is. Think about all the data that's coming out in the literature. I just scratched the surface on it. I picked some of the best papers to make a point, and I know I got pretty excited, so much that I'm losing my voice and I'm choking on it, but I can't keep it inside. And then the last thing I want to go through is there any evidence that conservative care designed to change alignment of the spine improves patient outcomes? We already know there's a plethora of surgical papers that are finding that changing a patient's spine alignment relative to their pelvic morphology indices, we already know that that's yielding better outcomes after surgical intervention. The surgeons are now verifying that. We actually know that conservative care-wise, we've got preliminary data that says the same thing. In randomized trials, when you compare treatment designed to correct a loss of the lumbar lordosis in chronic back pain, you get better outcomes than treatment that's only palliative in nature. Look at this. This trial was done in JMPT in 2012. How is it that the Blue Cross Blue Shield statement, no evidence, missed this paper? How is it that the ACA missed this paper? How is it that the Schwartz and Haas study didn't reference this paper, saying that there actually is evidence that says when you correct the lumbar curve in chronic back pain, that people do better at long-term follow-up compared to subjects that don't get corrected with their lumbar curve. And it's not just one randomized trial. Look at this. There's another one, clinical rehabilitation in 2012. It's not just two randomized trials. There's a third one, Journal of Back Musculoskeletal Rehabilitation in 2013. It's from my colleagues over in Cairo, Egypt. Ibrahim and Aliyah. They're amazing PT, PhD researchers. I've done a lot of work with them. They are investigating the early work that I did and the CBP research team did in the early 2000s on restoration of the lumbar lordosis with three-point bending traction. Thank God that Ibrahim and Aliyah decided to study this. 3 randomized trials finding that when we restore the lumbar lordosis, it improves back pain, disability, neurological issues with the H reflex, and flexion and extension kinematics. How is it that these 3 trials didn't make it into the Schwartz and Haas trial or paper that they did? I'll tell you how. It conflicts with the popular agenda where guidelines are taking away chiropractic x-ray rights to look at people with chronic low back pain. I'm Dr. Deed Harrison. Hopefully you enjoyed this presentation. I certainly feel a lot better now. I can go about my day because I got it all out. Have a great day.